Hey, welcome back to this episode of the 260. I have with me.
You have me, Adam Jackson, and my dubious partner.
You got Dan again.
And I'm here, actually. I'm not normally here recently. So.
With some stellar-looking glasses.
Thank you. I like your glasses, too.
Thank you.
Today we're going to be talking about a very important topic about cookie cutter medics and how not to become said cookie cutter medic.
It's pretty deep.
It is pretty deep.
We're going to get into the weeds.
That we are, so let's dive in.
That's going to be our new theme.
That is going to be
It's
your
me saying wee woo.
Wee woo. I'll have to put that in there.
All right.
If it works, it works.
Yeah.
You know?
So, in your guys' opinion, I wanted two of the best medics I know who helped me understand this concept as a tiny little grasshopper medic. What is a cookbook medic or a cookie cutter medic? And just let's start there. What is that? What does that even mean?
Do you want us to answer it, or do you want to wait for the two best medics you know to show up? And then
That was a good joke.
Oh, it was okay.
Thank you, man.
Wait, let me get my mirror. And
Yeah.
I'll take this one first.
go for it.
I look at being a paramedic. You know, we've got this thick book in our truck or on our PDF. It's our protocol book, our standing orders. It's like a cookbook, and the paramedic is the chef. So you have a chest pain call, you flip to that recipe page. Okay, nitro, aspirin, 12-lead, IVs, recognizing a STEMI. But a good chef doesn't use a cookbook. He tunes his recipes to his own taste. And I think after a paramedic becomes experienced or seasoned, they don't really write their own recipes, but they take the stuff that they've learned and add their own flair to it, their own seasonings. That's kind of how I describe it to some of my new hires. Like, memorize this book because that's important. You need to know this, but throw your own flair to it in a safe, practical manner that you can explain.
That was a really good analogy.
We kind of get that license to learn when you go out there. And the protocol books that we're given, it's like the guidelines. You know, I can't agree with Dan more. You know, the recipe is the recipe. But like Rachel Ray, she does palmfuls of salt. She doesn't do a teaspoon. The teaspoon is the cookbook. The palmful is what she believes to be true, what she knows to be true, what she's tested and has got the backing to know that this is a good recipe. So, yeah, no, you hit that right on the head, man. That's
treat to taste.
Yeah.
Speaking my language, I grew up 30-minute meals.
It's a great book.
I have the book.
Yeah.
I do have that cookbook at home.
It's a good book.
Yeah.
365 no repeats, not to get off track, but Rachel Ray's 365 no repeats. You can do 365 meals, not a single repeat.
That's awesome.
She's the best. I wonder if she would come on this podcast.
You can try.
That adage, like
Shoot for the stars and land for the, shoot for the moon and land among the stars.
Land among, yeah,
there we
yeah.
go. Wouldn't that be cool for our nutrition portion? We just get Rachel Ray. Be like, hey.
Yeah,
And in
what
this
can a medic eat
episode-
on the run that's healthy?
that's something we'll be talking about, actually.
Awesome.
Yeah. The December, we want to focus on like responder health in general, sleep, stress management, diet, moving your body, like just basics, and how historically terrible we are at managing those things. Because it's hard.
Fast
It
and
is
nasty.
hard.
That's usually what it is, fast and nasty.
And if anyone listening has some good ideas for that, reach out. We got some ideas, and we're getting ready to implement them soon so that we can get things ready for December. But if anyone has any good ideas, please shout them out. But anyway,
Absolutely.
so we're talking cookbook medics, some excellent definitions. Why does that protocol book sometimes bring us a little short of the end zone?
Well, when you look at the protocol book, it's based off of emergency medicine. It's tailored to the lowest common denominator, not somebody who is inept, but somebody who is entry level. If you break it down, like protocols on OB emergencies, we are trying to attempt to do what a OB has went to school for 15, 20 years and has a controlled environment We're attempting to do that in a chaotic environment. That protocol gives you that baseline of where to start. Where you have to break away from that is, this is your starting line. I have to approach this problem like this. When you self-educate yourself, and I'm a big proponent of being personable to physicians, especially OB nurses, because they are mother hens, but if they sense that you're willing to learn, you can take that protocol and not stay right in that definition. You can understand the concept that you're trying to obtain beyond the protocol. It's not just, it's not just an eclamptic seizure. It's what's everything around that. What is my depth of understanding on what they're trying to get me to do? Yeah, you got to take it at the baseline and expand on it. Don't just rest on the fact that I know that this patient gets this amount of mag over this amount of time. Boom, I'm done. I can rest my hat that I achieved what the protocol says. What's beyond that? What's her paragravida? Gravida para. Sorry for you people out there that hate when you say para first then gravida or vice versa. I apologize. What's her paragravida? What are her extenuating circumstances? Do we have polypharm going on where we've got multiple medications that are causing an issue? What's beyond this? What can I do that is within the guidelines of what I'm able to do that is the cutting edge? Is science saying, left lateral recumbent is good, but if you can pad this void, it makes a difference? What's new,
I think when you're I'm trying to think of the pattern behind what you're saying. It's basically why are these words here? Why? Why is, this protocol in place? Why did I choose those words specifically? Because, I don't know, depending on your amount of time in this business, you'll see things change. Mm-hmm. This is tweaked. This is taken out. This is added. And if you're just memorizing a protocol, those changes might not make sense, and it could be confusing for you. So you're really doing diligent by preparing for those changes that you might see, and for the patients that they don't fit.
Yeah. Oh, man. Ooh, that is one of my biggest pet peeves. The four of us could not go into a Macy's or a JCPenney or a Kohl's and buy one size fits all and fits all of us. Why is it that the protocol is a one size fits all for everybody? Tall, short, big, wide, old, young. Well, there's some discrepancy between old and young, but an adult is classified as 18 to 108. There are big differences in there. Beyond that protocol, there are things that will affect them differently should you decide to inflict your skill or decide not to inflict your skill. Just because it fits that line. Oh, I can give this patient this, or I can give this patient that. Do I really want to? Should I? It's not a black and white. We operate in the gray. It's not a one size fits all. It's a starting point, a guideline.
I remember getting really flustered, and I'm sure you remember this too. I still get flustered. I get flustered all the time. But when I was a brand new paramedic and would go on a call. I had quite a few ride-alongs with both of you, more with you, Adam. And you do such a good job of constantly trying to reframe calls why did you do what you do? Or why did you not do what you didn't do? And sometimes, paramedic school it's a stiff drink. You're tired, you're
all the
exhausted, and you're stressed to the max, and it's kind of annoying when you have someone be like, well, why'd you do that? Why didn't you do that? Why'd you do that? Why'd you do that? You're like, man, because the book said so. And that's a bad answer. That's a bad answer.
And as a brand new paramedic, that book will keep you safe. If you follow exactly what that book says, you're not going to get chart audits. If you have to explain something to a doctor, well, I followed the protocol on the CHF pulmonary edema protocol to a T. They can't fault you for that. Once you start getting some years under your belt, a little bit of courage, relationships with doctors, you can tell them, hey, the protocol says this. I did this. I really didn't break what the book says, but I added to it, or I took away, or I didn't do this. Section A, paragraph 2 says I should have done this, and I tried something else and it worked. So once you get that, some years I don't want to say you get to break or bend the rules, but you have more courage to read outside of the box.
You got to use that prefrontal cortex.
Oh, I love the prefrontal cortex.
Got to flex it. But it's hard when you're new because, I don't know, you're literally forming new pathways in your brain that've not been forged before. You've not gone down this road before. And so at a neurological level, it is difficult. It's not just stressful or anything like it's stressful, yeah, but you are doing something new neurochemically in your body. And it's important though, like if you're not constantly applying yourself.
I think you hit the nail right on the head. Both of you did. Talking about when you first come out, it is 100% warranted and accepted to be that person that follows that protocol to a T. But you have to put the onus on yourself to continue to grow. As soon as you become complacent, you start committing career death, spiritual suicide. You're not growing anymore. You're not trying to look beyond. You can master entry level in a year to a year and a half, and you can cruise that your entire career. The amount of impact that you're going to make on your patients and your community is going to dwindle, but you could successfully be a protocol cookie cutter medic for your entire career. You're going to have downfalls where nobody's going to come to you for advice, so your outreach is going to be smaller. You're going to have downfalls that as medicine changes, you're going to have to try to keep up with the times instead of being already ahead of the times because you're trying to grow. It's if there are entry level paramedics out there listening, like Dan was saying, it's okay to start there. It is 100% okay to start there. Don't rest there. That's where we start committing a career suicide, the stopping of the growth.
So I was going to bring up, we're talking about new medics, but what about when a medic goes and they get a admin type job? Do we see this there? And they're there for a little bit?
I do think you see it there more so than, I would say, the street medic, because they're glued to that protocol book, especially when they're doing, chart audits, or you get a subpoena and you go back into the office and you want to pull the chart and they're all, did you, hit all the check marks of your protocol book? So I feel like it's not that they've lost but they're so focused on the protocols and the new protocols that they're helping to write that they're just extremely focused on the book.
Yeah, I think that's
not in a bad
true.
way, because the book, they're there to keep us safe. They're there to keep us employed. They're there to keep us legally protected. And they're there to make sure that our patients get the care that the medical director has set for us. So it's not a bad thing.
Yeah. We're on a balance beam
hyper-focused,
here.
Yeah. I think it comes down to you are who you hang around. So if you hang around that protocol book and just that protocol book and nothing like educational, then that's just what you're going to be stuck around.
And it's like muscle memory. You're not going to take a 1-year paramedic. Ideally, you're not going to take a 1-year paramedic and move them into an administrative job. If you curl a 10-pound weight, right? You curl it for the first time, it's going to wear you down. You curl it repeatedly, you get used to pushing that muscle farther and farther and farther. If you go into that administrative role, when your muscle memory says, I have to grow, I need to grow, then that juggling job that you have to do as an administrator is muscle memory. If you stay the cookie cutter, the cookbook medic, your administrative style is going to be the cookbook medic. Because just like you said, it's the people you involve yourself around. Iron will always sharpen iron. Like people will always be attracted to like people. I think probably one of the things that attracted me and Dan to start our friendship was our love for looking for new, looking for ways to improve, nerding out on things. That started our casual conversation that grew into a friendship where we don't have to have a medical conversation all the time. So looking into the future or crystal ball 5, 10, 20 years from now, if we're both in administrative roles, we're going to still challenge each other every day. Hey, thinking about this protocol. Dan, we've got a good relationship. He's going to be like, hey, it seems pretty dumb. Are you thinking about the common denominator and the greatest denominator? We're going to have that open conversation because our muscle memory is a we're not resting on the black and white. We're staying in the gray. We're not resting on the protocol.
As I'm watching this conversation unfold, I'm trying to think about what this would be like for someone listening, especially the new individual. And I don't for a second want someone to think, okay, I am to be discouraged from following my protocols. That should go without saying, but let's paint that clear. So protocols are there for a reason, and they're usually rooted in science, data that has positive correlations with those actions or inactions, or those medications or those times or whatever has it. But not all protocols are created equal. And so I think if I'm trying to distill what we're all saying is that it is on the provider to ask why. Why is this protocol there? And if at the end of your conversation with yourself or with someone who is really intelligent and good at critical thinking is, you know what, this all adds up. Like, this is some good data. This is some good science. This is written very well. Great. But if your answer is, I'm not sure, keep going. Keep going. Ask people smarter than you, whether that be a more experienced provider, whether that be a physician that you have a good rapport with, or anyone. Ask why. And, maybe it's writing your medical director. Can you help me understand why you came to that decision? Or, walk me through what your thinking was here. We're on this balance beam of following these protocols, but thinking critically for when the patient falls in between these cracks. Like, something that we're always talking about in this podcast is the gray. Like, I think Barry said something really eloquent about, like, what we're doing is we're swimming in the gray, or what did he say? Do you remember?
Yeah, he
Something
said,
cool one.
Perfection is being able to swim in the gray. Okay, we thrive in the gray.
Our protocols are not gray; they are black and they are white. You do this, you don't do this. But many of our patients, it doesn't apply to. And so, like, how can I apply the concept of what this protocol is trying to get across? Coronary reperfusion, or hemorrhage control, whatever it is. Like, what is that concept, and how does it apply? And what can I do to make that apply to this patient who kind of falls in that crack? Obviously, follow your protocols, because they're there and they're going to get you in the target zone. Okay, they're going to get you in that bullseye area, but they're not going to get you there all the time.
No. One example I can think about that, and we talked about it earlier, is how things change. So a big buzzer would be like sodium bicarb. Like, we went from giving it to everybody to giving it to nobody to now we give it to hyperkalemia and renal patients. The game of how and why. How do I get this? Why do I get this? How did I get to this point? Why are they at this point? They being the patient. It starts at that protocol, but the onus is on us to expand on it. So you start going down a wormhole and you start learning that there's no specific study that puts sodium bicarb by itself. It's always lumped with ACLS medications. There are studies that show that there is benefit of it, administration of sodium bicarb in the first 10 minutes. I'm loosely quoting this. If you can verify that the pH is less than 7.1. If you give it when the pH is greater than 7.5, I think it's 7.5 or 7.6, somewhere in there, or maybe 6.7. Sorry, my kids.
You're so cool. So hip.
But if you give the sodium bicarb to a patient who is above a pH of 7.5, then you can cause some serious alkalemia. Now, where does that benefit us? Where does that come into play? Maybe one day we'll have an I-stat. But that isn't the patient that went into cardiac arrest, that has had comorbidities for a long time. Maybe that's the patient that just drank a C4, that is doing some serious cardiovascular workout, that we know that their pH is altered, that they're running at a too high of an acidic rate, or a septic patient that has had profuse diarrhea and vomiting for the past couple of days. When we know those things, we can apply that better. So the onus has to be on us to, yes, follow the protocol. But if we want something more than the protocol because we've done our diligence and went beyond, knowing what you're asking instead of just blanketly asking because you feel that you don't want to be a cookie cutter medic. You know what I mean?
So we're getting into some protocols here, and like you said, bicarb makes me think of like epi and a trauma arrest. Like for the longest time around here, like that's just something we did. Why not? It's cardiac arrest. Treat him with epi, right?
I reached out for higher education, different podcasts or seminars or symposiums that I went to, talking at these top level 1 trauma surgeons are like, how dare you guys give this epi in a traumatic arrest? And I started working in my brain. It's like, man, they're right. And why am I doing that? And then time played out and it's no longer indicated. So
you mind touching on that traumatic arrest protocol? By definition, if somebody's climbing a ladder and they fall off the ladder and they're in arrest when you get there, that can be considered traumatic arrest. But did the chicken come before the egg? You know what I mean?
Yeah, absolutely. You got to look at every scenario. Like you go to a party pin accident that the patient's in arrest. Well, you look at the vehicle, it doesn't add up. I think they arrested and then crashed. So now we're going to treat it as an ACLS. We'll do our CCR, do the EPIs, versus the car that's obliterated and, they have a steering wheel in their chest. So, protocol could go either way.
I was really proud of a crew. They had that call recently, and I guess they started talking to witnesses, and they're like, I saw that guy go unconscious. So they flip modes, and I was like, well, technically this is traumatic arrest, but I don't know, guys. Like, we're going to go ahead with epi. And I was like, made my heart grow like the Grinch. I was all happy.
And you can successfully cookie cutter that run, and nobody would bat an eye. Moreover, I think that if you were to call the hospital and you mention on your radio report that the patient is in cardiac arrest, he was in an MVC, that's going to trigger them sight unseen to think traumatic arrest. Now, you can clarify that when you get in there, but that's where, you have to look beyond just settling for, well, it's trauma, it's arrest. I can do this. This is acceptable. Be better than that, People are counting on us to be better than that.
That's the theme too. Like these protocols are, we have some good local protocols. I would say I'm proud of them, but there are circumstances where it's like, well, we can do better than just memorizing these. Okay, what's behind them?
Like us personally, we've sat in a few meetings where the protocols were discussed and we watched them be developed. And a lot of times, like, there's certain wordage that's put it in there, like preferred method or preferred this. And it's really up to the provider whether or not that is, for example, let's say it's like, oh, EJ should be like the preferred line on all cardiac arrests. Well, you're like, well, they don't have a neck. I can't find it. And it's either go in there with a needle and try to find that vein, or we're just going to IO them or find another line. Again, that's going to be up to the provider.
I love consider.
Or that.
Consider this, consider that. Mm-hmm. Do you consider what I'm out here trying to do right now?
Like I said earlier, Adam, not all patients are alike. Not all people are made the same. So we can't treat medicine like that all the time.
So how do you teach someone to think critically here? Like, because you guys both train. When you see someone who you feel like, they're in like survival, rote memorization mode, how am I going to try to cue this individual to peel back that onion, to look behind those layers?
You're rewriting computer programming at that point. If you get so deep into this is where I'm going to stay, it's almost like you have to help their personality find a reason why they have to do it. Because it's hard to rewrite. If you take somebody's 5-10 years, doing the same thing over and over and over, it's hard to find that common ground to say, hey, I believe that you can do something different. I believe that you can take yourself from a 7 to a 10. it's really case by case.
I almost want to say, so from my personal experience, I've seen this in both of you and a lot of other awesome paramedics. Just watch you do that. And you're like a double medic or you're training or whatever. And it was like, oh, like, this is your call, you're up. And then I see how you would have handled that or how you would have handled that. And then I compare that with, oh, I was gonna do that. Why was I gonna? And then we have a conversation. So I almost say, it's a difficult question to answer. I apologize. But just by leading by example every day, continually applying yourself, even though it's the exhausting thing to do, but it's who you are. You're in leadership positions. You have students. You have your precept. So I'd say just by putting yourself out there maybe and just leading by example.
Yeah, and that came true about a week ago. I had a bridge up paramedic working with me, solid as can be, going to be great. We had a chest pain call, and the chest pain was caused because the patient ate something, threw up when she got back to work, and the chest pain was more of a burning in the throat, acid reflux type feeling. Serial 12 leads, they were all beautiful, better than mine. Vital signs were rock solid. She didn't paint the picture of a cardiac event. So the bridge up paramedic I'm working with is looking at me with a bottle of aspirin in her hand, and I said, you do what you feel is right. I'm not going to give you an answer because, you could give the aspirin and go down that route, and you're going to be 100% on par with what the protocol says. We got a 46-year-old woman. She's diabetic. She's got chest pain. You do you. Well, my bridge up paramedic, I won't call anybody out, chose not to give the aspirin. And I'm like, I agree with you. That was a good call because I don't think this is of cardiac in nature. We transport to the hospital, gives a beautiful, well-painted med channel report. It just happened to be a doctor that answered it at this receiving hospital. And he goes, why didn't you give aspirin? Why didn't you follow your protocol? Okay, we'll give the aspirin. We got there, explained everything again, just as they did on the med channel report. And he was like, oh, I get it. Well, you should still follow your protocols and give that aspirin. Is it going to hurt the patient? Absolutely not. A little bit of aspirin in everybody's system, it's good for you. But, I praised this person for thinking, brand new as a paramedic, working on bridging up to be released on their own, and had that forethought to think, okay, this isn't painted like a cardiac picture to me. I think it's all induced from the vomiting. She had spicy food. It all makes sense. And, I encourage that kind of behavior. You could have went either way on that one. You could have done all the ACLS stuff and been perfectly okay. You don't do it and explain why in your chart. And then you're covered both ways.
Yeah. It's almost like looking at your patient.
Yeah, 100%.
Instead of looking at a page in a book and seeing how many people I can fit inside those words, more look at your patient and say, does this apply to them or does this not apply to them? Because that is like, that protocol is good. It's a surefire way to treat a patient effectively, a certain type of patient who's suffering from acute coronary syndrome. Is that what's going on? And I bet that person bridging up is probably exhausted because it sounds like they're applying themselves. And that's a good thing.
I think it's harder to come up as a paramedic these days than it was 10, 15 years ago. The data's hard to find, but when you talk about the question that you asked, you find somebody that's stuck in that cookie cutter role. It's hard to find because the discrepancy between somebody with Dan's years of experience and a new person is so vast, and that middle is so vacant. You're either a 1, 2, or 3 year guy, or you're the last of the 15, 20, 25-year guys. So you don't run into those as much. Finding that cookie cutter long-term medic, they're sparse. They usually, and it's no slam, it's more by design, they usually hide out in the shadows, But they are the next generation of the 15, 20, 25-year medics. So it's important for them to push that professional growth envelope and try to be beyond that.
They're the ones that you're not going to see paying out of their own pocket to go to a symposium or have their playlist full of podcasts. They just, I'm not saying they don't have the desire and the drive to do good paramedicine. They just don't have that extra, like, good enough is good enough.
You don't have to consume your life with it, but like, again, like searching for like those extra education, like understanding. And what I did when I was new, I'm like, could I explain this to someone? Like if I had a new person, can I explain why I'm doing something? And if I couldn't, then I went back to the book, or I found a podcast, or I found a YouTube or something to explain it, so that way I could explain it. Like that was like how I did it, see one, do one, teach one.
Absolutely.
Can you guys think of any circumstances, I'm sure you can, where the rigid mentality of just staying within these sentences of a protocol was detrimental to someone?
I think every VFib cardiac arrest that we run and the current protocols that we have with the gallons of epi that we're pushing, I think that's detrimental to them, to the patient. I'm excited to say that where we work, changes are coming in our cardiac arrest protocol, and it's going to be for the better of the patient. I can't wait till it comes region-wide. But, epi studies are out there. Yeah, you can give a rock a heartbeat with epi, but what's it doing to the brain? What's it doing to cerebral blood flow to the brain? Their outcomes just aren't what we're expecting or what we thought they were 15, 20 years ago. So, that's just one example.
Yeah.
A profound anaphylactic reaction resulting in cardiac arrest. I'd say epi's probably warranted and will be of benefit because we're trying to create vasal tone again, but not 99.999% of our arrests are not going to be of that nature. So just like you're saying, we can restart a heart and kill a brain at the same time if we're not vigilant in what we're doing, which luckily the science is catching up to us in this area that we're starting to recognize that.
I actually think of like the King LTs are like, yeah, man, we're rocking these airways. I mean, we're cutting off the carotid arteries, but like, man, we're these airways are in, we're getting ROSC. And
man, I was carrying the torch and the pitchfork on that charge. I hated Kings. I'm like, so this guy, for argument's sake, we'll call him Jimmy Buffet because he's never missed a buffet. He's got 6 necks worth of meat. And I'm going to put this BIAD in here, this blind insertion airway device, and push his carotid arteries completely shut. But a organ that I know I can take out of the body and it will beat by itself for 5 to 10 minutes without anything. But the brain starts dying in 2 to 3 minutes of deoxygenated blood or lack of oxygenated blood flow. That science doesn't work for me. Now, if I got an 18-year-old fit, 0% body fat, I could probably shove a garden hose down there and be no worse for wear. But again, one size fits all. Looking beyond that protocol, no, I'm not doing that. I'm not doing that today. This guy doesn't fit the bill for this. This girl doesn't fit the bill.
If anyone listening is newer and is, oh man, I don't want to be that guy. I don't want to be that cookie cutter medic. Is that me? Well, good thinking that, first of all. I would challenge you to look at these studies and look at airway control and pre-hospital management. Look at what EPI's doing. There's a lot of really interesting studies going on out there. And I mean, it's easier to go with the flow, for sure. No one's going to bat an eye at you. No one's going to pull you aside. But in life, I mean, that's a kind of a common theme. I mean, it's just easier to go with the flow, and we're in a job where sometimes that's not appropriate. Sometimes you've got to go against the grain a little bit to do what's right for your patient and to be the best medic that you can be. you're never going to know what you don't know, but you're also not going to really see anything if your eyes are closed and you're covering your ears up.
Several years ago, I ran into a situation where a employee at another service was going through a paramedic program, and we got into a very heated discussion. And he said, I will never work for where you work because you guys don't even carry cardizem. How am I going to treat AFib? I'm like, he might have a point. What can I do to treat AFib? Why am I not treating AFib? So then you start going down the rabbit hole, and then you realize every fifth commercial on is talking about somebody with AFib. Kareem Abdul-Jabbar has AFib, and he lives a normal, healthy life. So why would I want to? When would I want to? And if I wanted to, is there something that I could use? So the conversations became conversations with ER doctors, that became conversations with cardiologists from Parkview, and I got an answer. I'm not going to say what that medication is because you have to do your own homework. Like the guy from Reading Rainbow said, don't take my word for it. There is an option, but beyond that protocol, it says observe and contact medical control. When is it of detriment that I have to intervene? And when I intervene, what threshold am I pushing somebody past? There's going to be 1 out of 100 out there that being able to look beyond your protocol, you're going to be able to make a decision that is going to positively impact their lives. But it's 1 out of 100. I'm not going to give every patient that has AFib at a rate, RVR in the 130s, I'm not going to give them cardizem because the protocol says that I can, because their blood pressure, the first one I got was 98/60, but the second one I got was 116/68. Okay, they have an irregular heart rate. Maybe my blood pressure isn't accurate. But following that protocol, somewhere where they give cardizem, oh yeah, I can give it to them. But of what cost, you know?
Do you guys have cardizem?
No.
We do not.
No.
We have a lot of AFib, though.
I don't know if there is enough cardizem for Kareem Abdul-Jabbar.
God, he's like 8 feet tall.
Send it all. Yeah. His heart rate would be 300.
Another thing, and I don't want to go too far off on a tangent, something that's always bothered me, or I thought that was such a gift that we have in this area. When you talk about protocols, you know, we service an area of 460,000+ people. We have a hotbed of 260,000 people where you have 2 primary agencies that are doing all of your patient care. We are the hotbed for a study group. We get it all. Penetrating trauma, blunt force trauma, elderly, pediatrics, need I say more. We stay in the top 5 in the nation of pediatric arrest and pediatric trauma per capita. We have such an awesome gift that we should be trying to push the envelope to make things better for areas around us, you know. We should be on the latest and greatest. We should be doing things that nobody else is doing. That's our responsibility. We should be looking for ways to be beyond our protocols.
That should be your new motto, beyond the protocol.
Beyond the protocol. Get a forehead tattoo.
Yeah.
You
beyond
should.
the protocol.
I got a guy.
Oh, I ain't got no hair up there no more. I need to put something up there.
What's wrong with being bald?
Nothing. But you're tall and bald. I'm short and bald. That's just a bad combination.
You got something up there.
Yeah, it's stubbly. We can't all have luscious locks. Dan. Yeah, Kaitlin.
Well, you know.
Oh, just flip it.
Yeah, you can't. It takes a while to grow this, okay? I only cut my hair like once a year.
What do you guys? All right, so we're talking heavy paramedicine, which is we're all paramedics, but what about for those EMTs out there? Because their scope is much smaller, and I would almost argue that they really have to think critically about what they're doing. They have less in their toolbox.
Yeah, I think a double basic EMT truck is probably harder than if one of the 4 of us were paired up together for a shift.
Mm-hmm.
You know, because they have to not only make the decision of how I'm going to treat the patient, they also have to decide, am I closer to the hospital or do I wait for ALS? or,
Game's different.
it's a lot different. And I believe it's harder probably for them than it is for us to make some of these decisions.
One thing that I always tell, or even my EMRs, right? There's one thing that you can do that is super important, and that is do a detailed assessment, whether it's of your scene, your patient. You can get all that info. That info is way more important than people realize.
Absolutely. We deal with a lot of time-sensitive things when you're trying to figure something out. If somebody can talk to somebody and say, hey, when's the last time you seen X? When did they start complaining of X? Absolutely.
Something I think we're not talking about that goes hand in hand when you're stretching a protocol or when you're trying to go in between the sentences is med control. If I'm going to do something outside of my protocol, the next part is med control. So how do you go about doing that effectively? I think I noticed that, Adam, you keep talking about relationships with physicians. So they hear you, they know you, when you come up on the radio, they trust you because they know that you're a critical thinker. You're already setting the foundation for your next call that you're going to ask them for something. You don't even know what it is, but you're already setting that foundation by having regular conversations with them so that they know you and they trust you and they understand the way your brain works.
Yeah, there's certain physicians that have told me that when I hear your voice crack over the radio, they turn their head and start listening. Not that I'm any better than paramedic A, B, C, or D, but, I have a personal relationship with them, like you mentioned. So they know that if they hear my voice, and if my tone is different than, ground level fall, their ankle hurts, if they hear me start it off with a different inflection of my voice, they will listen. And, that's something that you earn.
And it's not that you're better, you're right. It's just they know you.
Yeah.
And if you never talk to someone, they're not going to, I don't know who you are. I don't know.
You have to force yourself into their, I call it the pod, but the little glassed-in area where the doctors usually sit. You walk in there and just, oh, what are you working on? That EKG looks funky, and they'll sit there and tell you about it for 10 minutes.
Yeah.
And it's great.
You have to make yourself available for growth too. Your protocol tells you that if somebody is CSTAT positive, they have to go to this facility. Your protocol tells you that if somebody is CSAT positive, you need to include this in your report. Your protocol says that you have to give a handoff. Your protocol says these things. But physician feedback, there's absolutely nothing wrong that when you take your patient straight to CT, hang back for 5 minutes because the neurologist is going to come after the ER physician, depending on your distance from the hospital. See what questions they're asking because our be faster is a lot different than their NIH. What are they looking for? You don't have to bog down a physician or a neurologist with a billion questions. Be available for what they're going to ask you. And you sure that there was no fall? Yeah, there was no fall 3 days ago. Or there was no fall, but there was one 3 days ago. Oh, they're on this blood thinner versus this blood thinner. Makes a difference versus not make a difference. At our level, we're still going to do the same, but that knowledge base that you're going to get from being there at that time, it compounds, Make yourself available that you can ask for physician feedback. Hey, doesn't violate HIPAA. You are directly involved in the care of this patient. Hey, I brought this guy in earlier. I gave him this. I felt like I wanted to do this. What do you think? Yes, you could have. It wouldn't have changed anything. Yes, you should have. I hope that we change that. That's where the growth comes into play. So don't drive them nuts, though, because they've got 45 patients at any given time, but be available for those teachable moments for somebody at a higher level than you.
Yeah, it's uncomfortable too.
It is.
Because it identifies you're approaching someone with a higher knowledge base, a higher experience base. They're up here. And so it's uncomfortable to kind of expose yourself. I don't know this. And in our field, that's kind of hard. we all think we're the best, and we're all, not all of us, but there's a lot of A types, there's a lot of hard chargers, and that does us a lot of good. It fits the bill, but when you talk about receiving criticism, which is something we talked about on this podcast, and if you ever want to grow, you need to do that, and you need to put yourself out there. And sometimes you might get barked at a little bit. Mm-hmm. That's okay. That's okay. You're not doing it to feel better about yourself. You're doing it so that you can stretch yourself, so that you can learn, so that you can fill in that question that is eating you up. You're like, what the heck was that? I've never seen that. I've never heard that. What was that? Ask them.
I think, Dan, you might be able to elaborate on this or agree with me. I remember when I was a newer medic, nothing was more of a gut check when you're cleaning up your stretcher and you hear that your patient that you just brought in is getting RSI'd or intubated right away, and you're like, what'd I miss? Educating yourself on the different parameters that they use to intubate versus what we do. It's easy to steer away from that growth and go back to, well, I'm just following my protocols and I'm not doing. It's easier to steer away from that. It's harder to say, hey, doc, what'd I miss? Help me out.
Yeah. And sometimes you didn't miss anything. Sometimes they intubate these patients just because they can't keep eyes on them for 8 hours straight. And that's their way of securing an airway and making sure they're not going to jump out of bed. They can put them on a ventilator and have an RT sitting there watching them and 100 monitors in their pod. Sometimes, it's been said to me before by doctors, we intubate for convenience sometimes because I can't stand there at the head of their bed and monitor them and wait for something bad to happen. He goes, you did fine by resuscitating them for me. You oxygenated them, you bagged them. They were doing good. It's just a choice we had to make. It's nothing you did wrong, but it's a tool that I have that I chose to use. So sometimes it's not a bad thing that your patient gets intubated 10 minutes after you drop them off.
Yeah.
And if you stay in that feedback loop and understand, it makes it easier to have the courage to look beyond that protocol, because like we've said 100 times so far, it is easy to be complacently okay with just following the protocols. Starting off, absolutely, but you got to grow, and that's part of the growing.
Earlier in my career, I had more doctors ask me, why the heck did you intubate this guy, than ask me, why didn't you? I brought him to you with a patent airway, and their stats are above 95%. And they're doing just fine with an NPA and a BVM. But I've had plenty of doctors say, why the heck did you intubate this guy?
Everyone has an opinion.
Yeah.
Yeah, I got a lot of them.
I'm glad you brought up that distinction between hospital and pre-hospital. We operate in one of those and not the other. Mm-hmm. And so just because, the hospital chose to manage the patient one way, that does not mean that you should have managed the patient that way. They have a lot more at their disposal, and it's a different game.
I feel like that gets lost. People are like, oh, why didn't you intubate, or why didn't you do this? I'm like, well, it's just me in the back. And if I would do X, Y, and Z with just me in the back, it wouldn't be as successful as if we do it here where you have multiple people. Oh, yeah. That does get lost.
One of our hospitals here locally in town, one of the things I like to do is take new paramedics and show them around their charge nurses station. They have a plethora of algorithms. So our 2 to 3 sentences on what we do for a CVA or a stroke, they have an algorithm. Our trauma criteria, that is 1 page, they have 4 different full sets of what they do. It's all in the care continuum, but it's like you said, these are different guidelines. I can't take it personally as a paramedic that my protocols said that I need to establish IV access. My growth says that this person's going to need fluid and blood, so I want 2 large bore IVs. Theirs says that they need a central line and they can't push anything through a peripheral line. If that's the case, I don't know. I can't hold myself accountable for that. I can grow beyond the IV access and get 2 large bore or whatever the case may be. but it's important to know that they operate different.
It's a different game, yeah.
I know sometimes it can be hard when you go outside of the protocol, when you push the envelope with like quality assurance and audit and reviews, and feeling like you're going to get nailed to the cross. I think one of the things that is done at the administrative level that hurts people is we tend to take shotgun approaches at things versus sniping something. So if Dan and I have similar runs, we have different outcomes, and my outcome is negative and Dan's is positive, I shouldn't have to worry about the ramifications that's going to come to me without proper guidance, and he shouldn't have to worry about losing a tool in his toolbox. I should get the personal attention. I should get the, hey, we appreciate that you're trying to think outside of the box, but we need to bring it in a little bit and slow back down. You know, when we do QAs and QIs, it's very important that we, in my opinion, because we all have them, it's very important that we highlight good things. And if there is a negative outcome, that we don't penalize other people that might look at things differently and have a positive outcome, if that makes sense. I think that's one of the biggest fallacies that we do. If Dan and I both tried 6 times at IV attempts because somebody was bleeding out, hopefully we never have to, but just for example, because somebody was bleeding out, and I tried 6 IV attempts because I wanted to give somebody Zofran, saying that you will be detrimentally punished or we're going to limit IV attempts to 2 no matter what, that's not the correct way to do it. You know, it's kind of a shaky example, but you know what I'm saying? Shotgun approaches are horrible. And I think it's important to say too, especially as a newer medic, a chart return or an audit isn't a negative thing. It's not always a bad thing. Somebody is trying to get clarification, or they're trying to help you grow. You know, maybe there was another path that you could have taken. Maybe your administrator is an outside of the box, outside of the protocol thinker and says, hey, like if it's Barry, I ran into this in the year of our Lord, 1773. You know, this is what I did. It's not always a negative thing. You have to take your pride and understand that you're trying to do something for the better of your fellow man. It's okay to learn by somebody pointing out something that you might have done not 100%.
Yeah.
I'm glad you said that too, because just because someone reaches out to you does not mean that you did something bad. And you're right. It's their job to ensure that people are keeping the community safe in the realm of pre-hospital medicine, you know, that they're thinking critically and they're doing what they should be doing. And I don't know, I think anyone who cares a lot about what they're doing, like they should want someone making sure they're doing a good job, you know. And just because someone reaches out to you doesn't mean you did a bad job at all. You know, I think we can all think of good experiences of clinical and poor examples of clinical reaching out to us, like biting your head off because, oh, well, why'd you give TXA outside the window? Like, oh, well, here's my reason. I don't know.
I'll give you a good example. I got talked to once upon a time where there was a lady who was a diabetic. She just came off of a flight. She was at a local restaurant, and she had a Dexcom. It was reading in the 50s, and she had like 2 peanut butter crackers. She was slightly diaphoretic. She ate the peanut butter crackers that brought her blood sugar up. She was from Florida. No family around, no nothing. It was her and her sister. Get to the restaurant, talk to the kitchen. She's like, I'm a diabetic. I've been a diabetic for 20 years. I'm not going to a hospital here in Indiana, Fort Wayne. I'm here visiting my cousin or something. I don't remember. Kitchen refused to bring any food out. There was no rolls on the table, nothing. I couldn't get this lady anything. She had nothing there. Her blood sugar, we rechecked it. It was 61. She said, I'm not going anywhere. I'm feeling better. Well, that 61 is only going to last so long. So nothing would be worse than a couple paramedics walking into a crowded restaurant, talking to a lady, they leave, and then she, for all purposes, kills over dead, you know? So I made the decision that I had oral glucose, not invasive. I gave her 30 grams of oral glucose. And I was talked to about treating prophylactically because the protocol said less than 60. I documented that her blood pressure was 61. What's the date today? October 9th?
6.
October 6th, October 6th, 2025. As I stand here right now, I do the same thing again because I look myself in the mirror. I know I did what was right, and that protocol was busted in that situation. That protocol didn't take into account the human factor. So when the clinical person was like, hey, I need to talk to you, we don't treat prophylactically. Okay, I get it. I'll take my lumps, but it's okay. I'd do it again.
Good topic right there. I'm really glad you said that because I like what you're saying about thinking ahead. What is going to happen after I leave? And am I going to come back here? If the answer to that question is yes, and maybe it's not you, or maybe you won't go back there. Doesn't mean it's not your problem. You know, I'm not going to go back there. Dan is. Somebody's going to go back to that residence and go on that individual. Is there a way that we can manage this here? Is there a way we can mitigate that experience? And that's what you did. You thought critically, you thought ahead, you stretched a little bit, but you also abided by your personal code that you have. I mean, you're the one that has to sit with yourself when you lay your head down at night. And it's not as simple as just, well, she didn't want anything, so I just left. Like, she could have been driving her car, and who knows what happened. I mean,
Absolutely.
I think sometimes people need some encouragement. You know, even if they're alert and oriented and they are able to make medical decisions for themselves like that, it's not just getting out of the call as quickly as you can so that you can go back to binging whatever or getting lunch or whatever. Like, you're there to help people in this community. And so what are you doing by leaving there? Maybe they just need a little push, you know? Have you told them what might happen if you leave? Not that you want to scare people, but
I hate to put him on the spot, but I'm going to call him two-time Dan. I've witnessed Dan, I don't know how many times, and refusals are always that hairy area, when you have a third-party EMS call and somebody wants nothing to do with this. They're like, Dan will take at least the first verbal assault before he even thinks about even changing anything. I've seen this man walk into houses and be like, you can turn around. I ain't doing it. You don't know what you... Oh, hang on. Let me talk to you for a minute, thinking outside of that protocol, you know? And he can probably attest to it more than I can. Those refusals, that's probably one of the hairier situations where protocols, the black and white doesn't work because there are all those things involved where the human aspect,
human element,
making somebody's bed for them, you know, things that the human aspect, they keep sliding out of bed. Well, I know why. Your mattress is 6 inches over from your box spring. Well, you know, we can fix that.
The last question for you two. You're in the ambulance. You're going to a run. You're trying to hype yourself up. What are you listening to?
I'm kind of the silent type.
You turned it off.
Yeah. That's when I focus, you know, especially based on what call I'm going to.
Yeah.
You know, if I'm going on a pediatric run, I got my protocol book open if I'm not driving, and I'm just, okay, Versed dose or, you know, Epidose for a peds alert. That's my time to focus. Sometimes maybe it's because I'm old, I don't know, because I love music and I love jamming out, but there's a time when I just want, you know, just the drone of the siren, and that puts me in the mode to go do my job.
Yeah, Adam probably doesn't listen to anything either.
I like to listen to Dan breathe on the way to the run. So I know what he likes to listen to after the run.
Yeah.
I hate to call you out, man.
Call it.
My man is the biggest NWA fan I've ever met in my life. I don't know. One of the first things that blew my mind is he knew the lyrics to the song. It's like, wait a minute, you grew up in Woodburn. This doesn't make sense. Yeah. No, I don't.
He's an enigma.
I don't think I have a song or anything.
I have a song story about you.
It's hyper focused. This is not going to be good.
Do you already know what I'm going to say?
I don't know.
Well, you were partners with my wife for a while.
Yes.
Do you?
Yeah, you have to tell now. Tell.
Do you remember there was a call or a whole day?
Yes.
Where you challenged each other to only speak in song lyrics?
Yes, and she killed it. Like, it was unreal. I didn't even know she knew that many songs.
I didn't either.
I think at one point she asked the question, and before the answer came out, she said, "Shh, don't speak." And I said, "Oh my gosh, you broke out the Gwen Stefani from like 2000. Like this is amazing."
She pulled out the codex.
Yeah. She said, "I can see right through you." I'm like, "Whoa, hold on. I am outmatched right now. I can't."
Did you challenge her or did she challenge you?
We used to, that's one of the fun things about the job. You try to find things to occupy your time. And it was after, I believe it was shortly after one day, she said, "You see those geese out there? I think I can catch one of them." And I have the video I can show you one day. And her trying to sneak up on it, I was like, okay, we're going to have a good day today. We did, I think we did the alphabet game one time where you have to A, then you start with B, then you start with C, whatever letter you have, you start the sentence with that. But I think I was saying song lyrics, and then she came up with the idea. I can't remember exactly, but I know it was fun. It was real fun.
That's the kind of thing that just makes not all right. That's not the thing that makes this the coolest job ever, but it's definitely part of it. Like you just get to do some cool stuff and have a lot of fun with some cool people.
We're 12-year-olds at Hertz.
Oh,
They get to play in a big box with a bunch of cool tools.
I remember I was with Troy, and we were doing something silly like throwing our trash in the trash can, like a basketball hoop or something. He's like, if I make this for the next call, it was a transfer, so it wasn't anything critical necessarily. You have to repeat what the individual says that you're talking to under your breath. The same exact thing that they just said.
that's great.
And so, like, you just said, "I love it." I just have to be like, "I love it." And I'm like, "What'd you say? What did you say?" And it was wildly awkward and uncomfortable, but it was funny. Yeah, it was fun. We should do that. If you guys have some fun stories like that listening, shoot them in. I would love to hear those.
Absolutely. We love those.
I got so many things I want to say, but I don't want to get neither one of us in trouble.
No.
It's like,
My
don't do it.
filter is right in front of my mouth right now.
We do have, what is it? I can change your guys' voices and stuff on here. So that way, I mean.
Oh, Roger.
Yeah.
This podcast is not Adam and Dan today, by the way.
Yeah.
All right, guys. Well, thank you for listening. Remember to like and subscribe and follow us on Facebook and Instagram. And leave it better than you found it.
Yay.